Okay, so chapter 13 of the ACE 6th edition Certified Personal Trainer textbook. And as always, remember, paper, writing implement, something so that you can read the material and rewrite it, of course, say it out loud. The things that we've already gone over any number of times, just keep those in mind so that you can study effectively and efficiency. Now, chapter 13, give you a little heads up here. You've done most of the heavy lifting, as I've said before, all the way up through these chapters, through particularly chapter 11. You basically have learned all about the IFT training model. None of that is going to be any different when we're dealing with people with chronic diseases. So chapter 13 is what should you now know, considerations for clients with chronic diseases. And so in the chapter, you're going to give you some information specific, let you know a little bit more about the actual disease. And then again, tables so that you can see all of the information in a formal, easy to read, easy to understand format. And that's kind of the thing when we are going through this chapter, keep in mind, and actually ACE tells you right from the beginning that you, just so you understand, the same principles apply through all the other types of scenarios we deal with apparently healthy individuals, with some specific guidelines on making some modifications, things to do and things not to do with these particular conditions. Please understand that any modifications that are needed, and they just literally they tell you right at the get-go on page 593, you got to base this stuff on the following factors. Base it on the individual. Remember, client-centered training programming, but the individual and the characteristics of their particular disease, chronic condition, right? Asthma. They have asthma. There's some really critical characteristics you need to know about somebody with asthma, somebody with hypertension. And by the way, they have hypertension. Is it managed? Is it not managed? Are they staying on their meds? Things like that. Do they have type 2 diabetes? Has it progressed all the way to insulin dependent diabetes? These are the things to keep in mind. And there are safety concerns, the severity of the disease. And that's what that initial kind of introduction is giving you. And so basically the idea for chapter 13 then, as we go through it, is to look at these specific cardiovascular disorders like coronary artery disease, hypertension, stroke, and PAD, metabolic disorders. These are somewhat common, sad to say, common issues that you'll see clients come to you with. And so again, as we move through, keep in mind, and I'll do this first with coronary artery disease, is that you're going to read an introduction to it. You'll get some more information on the actual condition itself. It's general information. Are there any nutritional issues and guidelines that go along with this particular? And the answer is going to be probably yes, in most cases, and what they are. And then the actual physical exercise training guidelines. And then that's what's going to take you ultimately to your particular table. Remember, grab yourself a sheet of paper and write that table. Now, what I would recommend you do, once again, is have a heading. So CAD, coronary artery disease, and that's going to be your topic because that's the specific of the chapter. Are these unique individual chronic diseases? Right into table 13.1, just as a for instance, and all these tables are going to give you the necessary information you need to make sort of the professional decisions on what modifications, if any, to the training you're going to make. So, for instance, on page 599, table 13.1, and by the way, you'll see this with all your exercise guidelines summaries, FITT, right? So fit, frequency, intensity, time, and type. And the one thing they do add is a row on progression, right? So frequency, and in the case of a somebody with coronary artery disease, how often should they train? At least 3, but preferably 5. So take a step back for a second, and I'll give you a little heads up. For the most part, pretty much almost every one of these conditions is going to have very similar guidelines. It's one of the things that kind of makes it easy on the cardiovascular part of it. Remember, you have the cardiovascular training, then you have the muscular training. The cardio training, for the most part, again, what you need to do is when you're going through these chapters, it's not just rote memorization. It's memorizing, but it's trying to do it in an efficient way where they start to make sense and you can create these correlations. And the correlations are pretty straightforward. We want people training 3 or more days per week, cardio-wise. And that's the way this worked out. Intensity is probably going to be, right? I'll close my eyes. I can almost guarantee you that the intensity for most of these are going to be what? Below VT1, right? That's going to be the initial recommendation. It's no different than what we did in the previous chapters. So when you're going through these tables, again, make sure you redo them, but then kind of keep in your mind, what are the similarities between table 13.1, for instance, and you'll get to the muscular training continuation on page 600 with hypertension. So hypertension is next, right? High blood pressure. And you've seen table 13.2 already, the new guidelines that are out that are already in the previous chapters. And then in addition, they're giving you some lifestyle management, some guidelines for people with hypertension. But now when you move, now again, there are subheadings here that give you some good, interesting information. But the ultimate goal is to get to these tables and understand and know this information. So just like table 13.1 on page 599, you've got table 13.4. And look at the frequency, most, but preferably all days of the week. In other words, 3 or more days per week. So right off the bat, your frequency, and I can actually show you frequency for stroke, 3 to 5 days per week. I'll just show you another one. Keep moving, and I'm just showing you real quick. 3 to 5 days per week. Look for the commonalities, and this way the memorization part of it is not as challenging. Intensity may be determined through the following methods, right? So the RPE below VT1, you're going to see this consistently throughout all of these particular chronic conditions. The muscular training components on these tables, those are going to vary a little bit more, but remember what ACE has done with the IFT model is they've simplified things. They've put it so that as long as you follow basic guidelines and there's nothing outrageous that you're dealing with your client, they're all going to be, people are generally going to follow very similar basic patterns of programming. And that makes the learning, the memorization of this particular chapter a whole lot easier. High blood pressure, okay, or hypertension, stroke. Look, people that have had strokes that are under clinical care are probably working with physical therapists. If they've had a TIA or a transient ischemic attack, a minor stroke, that's one thing. They will definitely want to be exercising and eating well. People that have had minor to major, no, stroke is minor, by the way, but on the minor or less damaging side, look, when you have a stroke, which is by the way, a stroke is simply a blockage or an actual bursting of an artery in the brain, right? So if you have a blockage in the heart, coronary artery disease, if you have a blockage in the arterial system in the brain, it's called a stroke or an ischemic stroke. And a hemorrhagic stroke is when the blood vessel actually bursts or hemorrhages, right? So that's what a stroke is. There's damage one way or the other. Sometimes you just don't even know, depending on the severity of it, you won't even know it. But nevertheless, stroke now has very similar guidelines, 3 to 5 days per week, right? Intensity, light, moderate intensity below below VT1 if you're looking at that. So light, moderate, or vigorous intensity. If heart rate um, data are available, again, we're just asking the clinical world to give us information, if possible, about this. We would much rather have a doctor say, look, by the way, just when you're training, this particular individual, just do A, B, C, and D. Got it. Not a problem. People that have had strokes that are coming back out of therapy and able to train again can do muscular strength training, perhaps 2 days per week, relative moderate, low to moderate intensity. And so those are your guidelines on page 608. Peripheral artery disease. Now, if you have a blockage in the arterial system in the distal part, normally it's the lower distal part of your body, the legs and then the feet. Um, you're going to people have problems and issues when it comes to walking for extended periods of time. So peripheral artery disease um, is going to affect the lower extremities more than anything else. When you get blockages in those arteries down there, of course, any part of the arterial system and therefore the organ, the muscles down in those areas, further along the actual arterial system, they're going to be affected by it. So your feet, your toes, things like that. And some individuals who have it, really bad, they can't walk for very long because they start to get the pain in their feet, and they just because there's no blood and oxygen getting to certain areas, and that's what PAD actually manifests itself like. So of course, nutrition, like anything else, it's just one of those things where, again, we're going to get you to eat more fruits, more vegetables, reduce saturated fat, things like that. But you'll notice on page 609, it's a little paragraph. Why? Scope of practice. ACE wants to make sure you don't get too much into the nutrition, right? Just, give guidelines and suggestions. Exercise has a direct effect on the cardiovascular system. So none of this should be of a surprise to you, but now table 13.6. Hey, look at that frequency, 3 to 5 days per week. Okay, again, nothing out of the ordinary. The only modifications you may see is going to come in the muscular training part of it. And again, 2 days a week, non-consecutive days normally is what is recommended. Full body workouts at moderate intensities. But again, intensity can be different for every client. This is why, once again, at the very beginning of the chapter, everybody's different, client centered. Okay. There are individuals who have peripheral artery disease at 40 years old, and there's folks who have it at 70, and they both come in at the same time. There's going to be some very stark differences in how you train them muscular wise, even though they both have the same chronic disease. Now we move into another sort of a class of, or another grouping called metabolic disorders, dyslipidemia. Although dyslipidemia, it speaks to all of the blood lipids, the entire blood lipid profile spectrum. Normally, you're going to see it as, or people will say they have high cholesterol. But normally, high cholesterol also comes along with high triglycerides and changes or negative changes to their LDLs and their HDL cholesterol, VLDLs, all of these other lipid parameters that are looked at by the clinical community. So dyslipidemia means that there's a problem with your blood lipids, whatever that is. And of course, there are nutritional issues as well. And so people that have dyslipidemia, what are we going to do with them? Well, there's some interesting information on table 13.7 that gives you some guidelines. You should know those guidelines, by the way. So table 13.7, good one to memorize. And I would imagine for most folks, some of this is not strange to you, and you may already know that total cholesterol, it should be below 200. That's ideal. But again, it depends on the level of HDL and the levels of LDLs. You see, there's a lot of information here that you would you'd want to know. And that's why we don't get into the, diagnosing of anything. We just want to look at the numbers, know the numbers, and then be able to help and guide individuals. So, and then of course, triglyceride levels, you should know these for yourself, by the way. So, and here's your guidelines for dyslipidemia. Now, it just so happens that in a case like dyslipidemia, the frequency recommendation is 5 or more days per week. You want to do as much as you can cardiovascular wise if you've got issues with your blood lipids. But that's not too difficult to memorize. We want individuals training 2 or more days per week from a muscular training perspective. All of these are looking very, very similar. Diabetes, type 1 diabetes is a genetic issue that where the pancreas simply does not produce insulin. Okay, it used to be termed juvenile diabetes. Right now, it's just type 1 diabetes because what's happening is that people with type 2 diabetes, where this is an issue where the insulin that is produced is not used effectively, and the sensitivity of muscle tissue in particular to the action of insulin is diminished, right? So insulin sensitivity goes down, right? We call it insulin resistance. So that's type 2 diabetes. What's happening is people with type 2 diabetes that don't control it or are unable to make lifestyle behavioral changes, ultimately their pancreas, which is able to produce insulin, although maybe at reduced levels, now stops producing insulin. And if that happens as the disease progresses, they become essentially a type 1 diabetic. It's not the way it's termed because it's at initial diagnosis, right? So if you're type 2 diabetic, and you become a type 1 diabetic, technically, you're basically what's known as an insulin dependent for the most part. People do use insulin even when the pancreas is able to produce. It just depends. It depends on the severity of the disease. But what you need to know really is type 1 genetic. Pancreas does not produce insulin. Type 2 is a lifestyle behavioral issue where insulin is not managed effectively by the cells of the body, particularly muscle cells, even though the pancreas does produce insulin. And so they give you a little bit more because diabetes is so prevalent today and it's so damaging to the body. ACE gives you a little bit more information about and the comparison of type 1 and type 2 diabetes. Look, at the end of the day, type 2, move over to 618 exercise guidelines. Train as much as you can. I mean, honestly, if you got diabetes, you should be active, working out, training as much as you can. I mean, it's kind of simple. It really is. So frequency, 3 to 7 days per week, 3 days of vigorous. At the end of the day, we want to get your body moving. We're going to get your muscles working. There's kind of this entire bucket of issues. When we deal with metabolic issues and cardiorespiratory issues, what caused it? We don't know the exact direct cause, but I can tell you this much, and you already know it: nutrition and lifestyle. Okay, not for type 1 diabetics, for instance, but for sure, these lifestyle behaviorally managed issues, you need to train every day. You need to be doing something every day. That's what helps you in memorizing some of these tables. And so there are modifications, right? There are guidelines that you definitely want to know and understand. Then there's the metabolic syndrome. If you haven't heard, it's called the metabolic syndrome, is simply a cluster. It's a cluster of conditions. And so when your blood work gets taken, when you look at your waist circumference, elevated triglycerides, reduced HDL, when you add all of those together and they come up in this pattern, right, you have what's known as the metabolic syndrome. It's not a disease in and of itself. It's simply a condition, right? It's a grouping or what's known as a cluster of conditions, elevated waist circumference. And again, it's really important to know this. Bottom of page 619, elevated fasting. So think about it. All of those issues and problems that can go wrong from not training and not eating well leads to the metabolic syndrome. So there you go, nutrition and lifestyle, exercise, and then table 13.2. Look again, look at the frequency. 5 or more days per week. Do you see the correlation here? Do you see the connections? This is what you would be writing down, metabolic syndrome. And now, of course, and by the way, same thing with the muscular training, frequency, a minimum of 2 non-consecutive days per week, preferably 3. You're going to see that in pretty much all of these. And now ACE is going to help you out here a little bit with the movement method, ABC approach. Just look at some of the ways that they recommend that you have a conversation with a client. Now, pulmonary disorders. So you've got all these metabolic disorders, and now we look at pulmonary disorders. And for the most part, I mean, unless you're working in a wellness center. Now, I ran a hospital-based wellness center for many years, and we saw people with COPD. Of course, that's who we were dealing with for a large part of our clientele, average people as well. But we saw people with COPD. Now, these individuals, of course, they had oxygen tanks. They were on very specialized training programs. We monitored their blood pressure before, during, and after their training, and we had highly skilled trainers. But for the average trainer, if somebody has these pulmonary disorders, the goal here is to essentially understand it well enough, so that you can deal with any issues and problems, and there are safety concerns. Um, so with the pulmonary disorders, the COPD, chronic obstructive pulmonary disease, you're going to have to abide by some really, really strict safety guidelines from a training perspective. But the main focus in this chapter is not so much on COPD, it's on asthma, which you're going to see. You may have asthma. Now, as long as it's controlled and you have your little puffer, you should normally be okay. The key here with asthma is it controlled, medically controlled? Um, my wife has asthma. My 2 daughters have asthma. Fortunately, I don't. My sister, I probably know more people with asthma than people that don't. But again, as long as it's controlled, um, you can pretty much do anything, and your clients can pretty much do anything. And the suggestion is that you always have a rescue inhaler. They always bring theirs, and you always have an extra one on hand just in case they forget, which they will. Asthma is just it's an inflammatory response in the bronchial tubes in your lungs, exercise induced, allergic induced. Those are the things that quite often we see, particularly where you're training individuals. That could be a problem. But again, as long as it's managed, and when I say managed, that means that that individual with asthma is doing the medication protocols that are specific to what their doctor told them to do, and um, that's basically what it is. And quite often, people just don't stick to their medications. Advair is a classic example of a anti-inflammatory medicine that's supposed to be used on a regular basis. And some people go, I feel fine, so I'm not using it. That's not a good idea, because asthma is a chronic disease. You don't get cured of asthma. You got it all the time. The question is, what's going to kick it off? And so you want to maintain this constant anti-inflammatory uh, medication management, and then as needed during exercise, you can use your puffer. So general guidelines to help people with asthma on page 626. And there it is. Rescue clients should have a rescue medication. That's your that is your that's your saving guideline right there. You better have it. If you don't, I have an extra one, but I'm not giving it to you. You better make sure you bring yours next time. Um, and then, of course, there is a list, of course, of uh, program guidelines that you need to manage. Table 13. Hey, what a surprise. Frequency 3 to 5 days per week of cardio respiratory training. You're going to see the same things. So just keep that in mind as you're going through, once again, guidelines for clients with chronic bronchitis and emphysema. These are other issues that you for sure will see. But again, these are chronic issues. Normally, they are being managed by the clients physician. And let's say so other chronic conditions, again, remember your tables are all going to look very, very similar with some minor modifications that are generally easy to differentiate based on the chronic condition. Other chronic conditions now, ACE is saying, look, there are other conditions that people you might start seeing people more and more with, and cancer, of course, which is the general, vast, general word for just a plethora of diseases and conditions. And so cancer has, if an individual does have cancer, you can read through. By the way, for the most part, this is all based on what the doctor is telling you. Okay. Cancer patients, if they're in remission, if they're going through chemotherapy or whatever the case is, these individuals need to have been given clearance by their physicians. Quite often, individuals, for instance, for instance, if a woman has had breast cancer and she's just finished a round of chemo or even radiation, sometimes they're done together. They are not feeling like they want to be training and exercising, and yet their doctor might actually say, look, it's a good idea if you get out and you start walking and do whatever feels comfortable, get on a good nutritional plan. At some point they will release them for exercise. The more you know about it, the better able you are to deal with issues and problems that go along with it and give them the right training program. So that's what table 1315 is telling you. Once again, frequency 3 to 5 days per week. Okay, frequency of muscular training 2 to 3 days per week, and then again the things we already know through the IFT model on intensity, time, and type. Osteoporosis. Okay, cancer is what it is. Here's where I've probably dealt with more people with osteoporosis and some type of arthritis than just about anything else. Dealt with a lot of people with diabetes, lots of people with asthma, but this condition in particular, especially with older men and women, particularly women that have been diagnosed with osteopenia, which is sort of a precursor to full-blown osteoporosis. And so osteoporosis then has, right, read through that, because now there are some really important things to keep in mind when you're doing training with folks, right? There's things you got to do. We need to train, right? We need to train, but it's osteoporosis, so the bones are brittle or weak. So you got to be really careful with your technique, your range of motion, how far you lean, bend, and that's one of the things that they have here. There are currently no established guidelines on contraindications, but you just got to use your brain for a second. The bones are brittle. They will break easy. So you can't be doing things that are going to extend, hyperextend, or put undue stress on the joints, particularly. One of the things they do note is that as you get towards the head of some of the long bones, particularly up to what's known as the epiphyseal surface of those bones, there's weaknesses that occur in those particular areas. The scapula, for instance, the hips, the pelvis can get thin and brittle. And so just keep in mind that now you're really getting into this is some real stuff that you would be really concerned about with the particulars of training. Somebody with type 2 diabetes, I'm not as concerned as if I'm doing, bending or flexing forward. But with somebody with osteoporosis, now that's a mechanical concern, right? It's not a metabolic concern. I mean, it is, but from the training perspective, it's not a metabolic concern. It is a actual mechanical issue I got to uh, keep in mind when I'm training people. So table 1316, very important. Arthritis. Arthritis, for the most part, remember there's two basic types. There's what's known as RA, which is rheumatoid arthritis, and appears to be a autoimmune issue. And so that, in other words, what that means is we don't know what the heck is causing it, to be honest with you. It's treatment based. Osteoarthritis is the most common form. It's not so much an autoimmune, but it's a response to things that are occurring in and around the joints. Often we see it, particularly in the fingers, but it happens in any joint of the body, especially when you start seeing um, clients with shoulder issues, hips, things. I'm pretty sure I do at my age. I got some arthritis in my hip, but I beat myself up really good. And you wake up in the morning and it's just uncomfortable. Well, clients come to you with that. Okay, and so you need to know about it. And by the way, people with rheumatoid, with RA, this is a challenge. It really is a challenge because the level of intensity that you're training people at, it's almost like two separate, honestly, it's almost like two separate diseases. Um, but you got to be very, very careful because, again, 3 to 5 days a week of cardio. Perhaps the muscular training part for people with RA, if they're going through a flare up, for instance, can be a little bit of a problem. Don't beat people up with arthritis. Don't beat these people up and try and do 1 rep maxes. There's certain things that you just need to use common sense about when you're training people. ACE is very conservative in the IFT model because the idea is that the average apparently healthy person is not an athlete, and you just don't want to train them so that they cannot recover from workouts and then they get demotivated and discouraged. Same thing here with people with these chronic conditions. So table 17 on page 641 is your last table in this particular chapter. Again, keep in mind the way you memorize the information is by reading, rewriting. But in today's fitness industry, health and wellness, fitness, we're seeing more and more people with these chronic conditions. And that's great in one sense, is that the more of these individuals that are taking their health seriously and coming to the trainer, the more responsibility we have as fitness professionals to know their conditions and know when to work with their doctors, their clinicians, but also know on our own end, our responsibility, our scope of practice, how we can help them because of that particular condition. Okay, so that ends chapter 13. And as usual, again, read through the summary, and I look forward to seeing you chapter 14.